My name is Vanderlene Kung, and on behalf of the RPS Education and Training Committee, it's my pleasure to welcome everyone to today's GlomCom RPS Sunday Seminar Series. Our speaker will be Dr. David Howell.
Dr. Kung, thank you for that kind introduction, and thanks to GlomCon and the Renal Pathology Society for this invitation to talk to you today. Also, I want to give a little shout out to Nicholas Kozakowski, who's the person who actually first reached out to me about giving this talk. So thank you, Nico. So my talk is entitled Not Everything Under One Umbrella, and I've subtitled it Two Things in One Biopsy. I have no conflicts of interest to disclose. So today we're going to be examining some renal biopsies that contain more than one pathologic process. And I want to split the talk into two parts. The first is to look at some of these biopsies and try to explore the relationship between the multiple processes that we're seeing in the biopsy. In the second part of the talk, I want to explore some diagnostic pitfalls where you find one thing and then get lulled into a sense of security and miss a second thing. And I want to talk about situations and reasons why that might occur. Now, I'm not the first person to consider or talk about this. No less an authority than Fred Silva has actually talked about it. If you go to the RPS website and click on member resources, there's an area called Fred Silva Podcasts. And under that, there's diseases of the kidney. Fred was prolific with these podcasts. And one of those is called dual glomerulopathies. And I would really encourage you to log on and listen to this. It's a pretty quick listen. It's only about 8 or 10 minutes long. And like everything that Fred said or wrote, it's chock full of very important and interesting information. So when you're considering a biopsy that has two pathological processes represented, there's an interesting kind of dual competing set of paradigms with which you can look at it. The first of these is the famous Occam's razor, which was promulgated by William of Occam back in the 1300s. Occam said, among competing hypotheses that predict equally well, the one with fewest assumptions should be selected. So all else being equal, it's most likely if you see more than one thing in a biopsy, they're liable to have one root cause, according to William of Occam. Now, the counterpoise to this was proposed by John Hickam. Hickam was an internist who was actually at my institution in the 1950s. And Hickam's dictum is patients can have as many diseases as they damn well please, or sometimes unlucky enough just to have two or more things that are totally unrelated. Okay, so here's a list of possible interrelationships between two things that one might encounter in a single biopsy or in a single patient. It's possible to have two things that have one root cause from which they flow. Possible to have a second thing that's a consequence or a product of the first thing in the biopsy. It's possible to have a second thing that's a consequence of treatment of the first thing. There's a gray zone where you encounter two different pathologic processes that maybe have some circumstantial evidence for relationship or relatedness, but you can't really be sure. And finally, down at the bottom, there are two things that you think are just totally unrelated. So here's a little color-coded diagram. The first three things in this list in red probably hew to Occam's razor. So they're explained by one root cause. They do, in fact, fall under one umbrella, contrary to the title of the talk. And if you treat the root cause, you might be able to treat everything with a single treatment. Down at the bottom, we have two totally unrelated things, and this is clearly under the aegis of Hickam's dictum. You definitely here need more than one umbrella, and you probably need more than one treatment if you want to solve all the problems. And then the thing in yellow here is kind of in the gray zone in between. Could be Occam, could be Hickam. So let's start with this first category, two things with one root cause. I'll illustrate with a biopsy from a 79-year-old male with acute renal failure. He had a lot of clinical indicators suggestive of microangiopathic hemolytic anemia. His haptoglobin level was undetectable. His fibrin D dimer was way up. I think he probably had schistocytes on his peripheral blood smear. He was also noted to have a decreased C3 level. And just as an additional thing to throw in, he had a monoclonal gammopathy of undetermined significance. This was an IgG kappa M protein. The clinicians thought that he probably had a thrombotic microangiopathy. And the clinicians were actually right. Here are a couple of fields, high power view. We'll get back to the glomeruli.